is less than 10%, but once we exceed the age of 60 to 69, this stage 2 or 3 up to 20% and rose up to 35% with the population over the age of 70. In 2015, they put the slogan of kidney health for all to shed the light about what is chronic kidney disease, how it's treated, how it's detected, what are the causes of CKD, who is at risk, and how it can be prevented. And because this is considered as a public health, 1 on every 10 people in the population are affected and having some degree of CKD. So CKD currently increasingly recognized in multiple countries as a public health issue. This is because the burden of CKD has moved from, within 2 decades, from the 35th to 19th place over in the less than 25 years as cause of death. This is based on the Lancet publication in the 2015. And currently, despite the different report from all over the countries, we know that the mean estimation of CKD prevalence worldwide range between 10 to 16% of adults, and mainly it is about 13.4% as CKD prevalence. In 2016, very important, the slogan about kidney disease and children, because act early to prevent it. And this is very important study. They look on the frequency as a cause of CKD in pediatric group, and knowing that as glomerular disease range between 6 to 20%, and mostly due to systemic nephrosis resistant, steroid resistant nephrotic syndrome, while the structural and other causes as rose up to 50 to 57% of causes as the cause for urine tract malformation. So if early detected, it could be prevented for CKD advancing and progress. And here the importance of this publication in pediatric, that on the left side, you have all this one as anemia, hypertension, all this one, it could affect your image once you are in the adulthood. So if we have undiagnosed or untreated anemia during the pediatric age, it may lead to liver ventricular hypertrophy in adult. The hypertension could lead to CKD progression. The problem of growth hormone axis disturbance could lead to short stature and growth failure. Endothelial dysfunction, medical calcification could lead to myocardial infarction and arrhythmia. Of course, the CKD and MBD with hyperphosphatemia lead to bone deformity, fracture, and ectopic calcification in the adults. So currently, what we are as nephrologists, once we are following a patient named with the diagnosed as FSGS, CKD, it may be the reflect of renal hypoplasia during the pediatric age, or patient with hypertension, albuminuria, CKD, because of low nephron endowment during the pediatric age, or bladder dysfunction because of untreated or undiagnosed vesico-urethral reflux, or any CKD of unknown etiology, could be because of genetic kidney disease during the pediatric age. In 2017, they shed the light about kidney disease and obesity. So healthy lifestyle for healthy kidneys, because the obesity is a well-established risk factor for developing major precursor for CKD and ESRD, such as diabetes, hypertension, and kidney stones. The strategy is to reduce the excess weight and to prevent the development of diabetes, hypertension, and cardiovascular disease in order to reduce the risk of kidney disease. Currently, about 600 million people in the world are affected by obesity, 220 million of which are school-age children, and this is very alarming problem. The individuals affected by obesity have an 83% increased risk of CKD compared to individual with a healthy weight. In 2018, they put the slogan about kidney and women's health. This is in order to include the female to be treated for CKD, to value and empower the treatment for female or women health, because the CKD is the 8th leading cause of death in women. Cases above 600,000 female deaths per year, and more likely to develop in women. We know that the prevalence is slightly higher than men, about 14% the prevalence of CKD in women compared to about 12% in men. And we know that more common in women, we have to have the lupus nephropathy and the kidney infection. In 2019, kidney health for everyone, everywhere. This is because of to call for universal health coverage for prevention and early treatment of kidney disease. And the year after, last year, 2020, the kidney health, the same slogan for everyone, everywhere, in order to act from prevention to detection and equitable access to care. And this year with the same slogan, kidney health for everyone, everywhere, but living well with kidney disease. So kidney health for everyone, everywhere, in order to prevent and early detect should be a policy that can be successfully achieved. Prevention and primary care for kidney disease should be placed within the context of their universal health coverage program. This is for policymakers, for nephrologists, for healthcare professionals, and for the general public. So just to conclude with the key messages, that currently around 850 million people suffer from kidney disease, and kidney disease is currently the 11th leading cause of global mortality, and between 2 to 7 million premature deaths for lack of access to dialysis and transplantation worldwide. So many countries, they don't have the facility to treat patients with the ESRD. And a drastic change and improvement in kidney disease prevention and treatment is needed. Screening for high-risk individuals and early diagnosis and treatment are cost-effective to prevent or delay end-stage renal disease. And this is very nice initiative by the International Society of Nephrology. It's available on website, ISN. You can have this toolkit, ISN Ckd Early Identification and Intervention Toolkit. You have the quick guide and infographic, teaching tool for health, conference report, article, and resources for patients. With this, I will conclude, and thank you very much.
Thank you, Dr. Bashir, for keeping up with the time, and thank you for the nice review of the World Kidney Day initiative and activity over the years. And I will open the floor now for any questions or comments.
We would like also to welcome all the newcomers. Now we have 125 participants joining our meeting, and we can receive questions better through the Q&A, and also in the website and the Twitter we can also receive the questions for those who have more convenient communication through the Twitter or social media.
Okay. I think I did not receive any questions here. Oh, there is one question from how can we create awareness about it? And I think he's talking about chronic kidney disease. Dr. Bishir?
Yes, this is the decision for all health workers to be aware. So the ambassador for this CKD, the World Kidney Day, are the nephrologists. So to spread the right message first for their colleague in hospital, in any health institution, and to have a special lecture about the CKD. For public, we try to make a campaign over the years about screening the high risk. Always we try to spread the message that if you are at risk as age over 50, smoker, family history of CKD, please check your kidney function, check your blood pressure, check your diabetes, your blood glucose level. Very important for the general population to be aware about prevention of diabetes and hypertension for CKD prevention.
Okay, thank you. There are two more questions here. Is US elastography has an addition to early diagnosis of CKD?
I'm not sure I have an updated information about elastography to early diagnosis. I'm not so expert in this one.
Also, of our colleagues who join in, other faculty presenter, if they want to contribute to this discussion, we still have plenty of time, alhamdulillah.
Okay.
Dr. Ahmed Al-Khanezi, if you have any input, please don't hesitate.
I think Dr. Attar has commented very well on the questions.
Okay, the second question, do we have an electronic method as high alert for kidney disease in patients?
Currently, we don't have, as I heard that we have a suggestion to form a national one about AKI alert for all in-hospital patients. And our colleague at National Guard Hospital started this project. Mostly, maybe we have to establish with our nephrologist and this web-based tool in order to have an alert in the hospital. I believe it's available at King Faisal Specialist Hospital. I'm not sure about King Fahd Specialist Hospital or Aramco.
And I can add more here. The problem with the alert, and most of the, or some of the country have used, or some of the nephrology department or sections has used this as an early referral tool to nephrologists using eGFR, calculated GFR, or estimated GFR. Unfortunately, it's nice to have this one to know or to refer or to alert the healthcare professional about the chronic kidney disease or kidney disease in general. The only problem with that, it increases the referral to nephrologist if we depend only in the GFR, because as you are all well aware, the kidney disease in general or chronic kidney disease is not defined only by the GFR. We have to have certain changes, pathological, radiological, or in the urinalysis in order to call it chronic kidney disease. So yes, there are, and some hospitals they are using it, but unfortunately, the drawback of it increases the referral to nephrologist. There is another question: what CKD stages do you recommend referral to nephrologist?
I think for our nephrologists, the interest is to have the sedation early as possible, but could be from stage 3 to stage 4, based on the availability of nephrologists in the health institution. But sure, from stage 3 is better to be referred to the nephrologist.
Excellent. And just to update the attendee as well, the Saudi Health Council, along with the Vision Realization Office of Ministry of Health, we are now, I'm one of the members in the committee. We are doing a national kidney disease strategy, which will involve the pediatric as well as adult, which will focus on early prevention, detection and prevention of the disease as well, and early management, and then early referral for renal replacement therapy, which will inshallah finish in around 2 months, which will shed light on the management and on the whole strategy for the whole country about the chronic kidney disease. There's one more question. Which stage, if CKD, the nephrologist is the one responsible for treatment of anemia, from which stage it is for them? So, Dr. Bashir. So,
the nephrologist is one for treatment of anemia. Which stage is it from? I don't. I'm not sure I well understand the question. At which stage the nephrologist should treat it? As soon as possible, once it's detected. So from which stage? I don't know if you...
Maybe usually we don't see the anemia early on in the early stages of chronic kidney disease. We start to see the anemia from stage 4 and on, because if you see anemia early on, think about other causes of anemia rather than chronic kidney disease as the ultimate etiology of the anemia. And I think at the time of referral, if let's say if a patient with chronic kidney disease stage 1, 2, and 3 is being treated by a primary care physician or a family physician, they should be the one who's searching for the etiology of anemia. And most of the time, it's not related to chronic kidney disease, because chronic kidney disease anemia usually start at stage 4 and on. And after that, the anemia of stage 4 and 5, I think the nephrologist is the one responsible for treating the anemia related to chronic kidney disease at this stage. Then there is one more question. When would you recommend referring CKD patient to a clinical dietitian?
So the same as for anemia, at early stage, maybe there is no symptom for that indication, but maybe from starting stage 2 and 3 to educate the patient about the specific nutrition to be followed. So always between stage 2, 3 to be guided by the dietitian. We can't hear you, doctor.
It is of paramount that the patient with chronic kidney disease receive adequate education at earlier stages, as you mentioned. Having said this, in certain programs, chronic kidney care program, they have what they call kidney function clinic, which is taking care of before dialysis. And it's the only intervention that patient education which has been found to reduce mortality. If you see intervention related to anemia, intervention related to bone mineral disorder, these changes, they have trends to reduce mortality. But the other changes, which is education, and one of them is dietitian to educate the patient about their diet, it's the only intervention which was found to have an impact on mortality. So it is really important, and I think, as you mentioned, early on is important. So, however, it's important as well for nephrologists to understand that these changes related to chronic kidney disease start a bit at some of them. They start early on, even at stage 1, in particular related to bone mineral disorder, but maybe manifest at later stages. So I think early intervention, as you mentioned, is important. I think there are no more questions, so I will leave the mic to Dr. Hanan to introduce the next speaker.
Thank you, Dr. Mohammed Al-Ghanem and Dr. Bashir Al-Attar. As usual, he gave a nice summary and the beautiful slides. There is a bit of change in the schedule. The next will be delayed to after Dr. Ahmed Al-Khanizi. He will present a talk about treatment of lupus nephritis, the update. So Dr. Ahmed Al-Khnezi will be next. And then we'll take a short questions, then a break, then we'll continue with as scheduled with Dr. Abdul Razzaq Amir, which will be recorded, as I mentioned, because he's attending with his father who's undergoing operation. We wish him and we pray for his father to get well. So Dr. Ahmed, if you are ready.
Yes.
Yeah, please, the mic is yours, and you have 25 minutes.
Bismillah ar-Rahman ar-Rahim, and I would like to thank the organizing committee for organizing this nice symposium and for inviting me to be part of it. The topic that I will discuss today is the treatment of lupus nephritis. And basically, I will tell you what we've been doing so far, treating patients with lupus, and what we will be doing in the near future based on the new evolving data and studies. In the beginning, I will give you a background about lupus nephritis. So around 35% of adults with SLE have clinical evidence of nephritis at the time of diagnosis. And 50 to 60% develop nephritis during the first 10 years of their illness. And the prevalence of lupus nephritis is higher in certain groups, such as Blacks and Latinos. And though it is not that common to affect men, but when men are affected, usually they do poorly as compared to female. The overall survival of patients with lupus is around 95% at 5 years and 92% at 10 years. However, people with SLE who have renal involvement, the survival is less. It's around 88% at 10 years. And renal involvement tends to occur within the first 2 years of the disease. And after the first 5 years, it usually goes down. And the treatment that we have available so far is quite limited. And the options are toxic and only modestly effective. So the American College of Rheumatology published a case definition for lupus nephritis. So a patient meets the criteria of lupus nephritis when they have proteinuria of greater than 0.5 grams per day or 30 milligrams per deciliter by dipstick. But nowadays, we rarely do 24-hour urine collections to quantify proteinuria. So we frequently do urine protein over creatinine ratio, and anything more than 0.5 is considered lupus nephritis. And the other definitions are cellular cast, whether they are RBC cast, white cell cast, granular, or mixed cast. And of course, the gold standard to make a diagnosis of lupus nephritis is by doing a kidney biopsy, where we see immune complex mediated GN, typically with a full house pattern. The indications for renal biopsies, the indications are quite a few. If there is an increasing serum creatinine without having a compelling alternative, such as sepsis, hypovolemia, or medications toxicity, then this is a criterion for a kidney biopsy. If there is a confirmed proteinuria of 1 gram per day or more, this is another criterion. And if there is a combination of proteinuria of 0.5 grams per day plus hematuria, or a proteinuria of 0.5 grams per day plus cellular casts. So lupus nephritis has been classified into 6 classes according to the ISN and RBS classification from 2003. Class 1 is minimal mesangial lupus nephritis, which is close to normal. Class 2 is mesangial proliferative. Class 3 is a focal proliferative. With focal, we mean less than 50% of the glomeruli are affected. Class 4, if there is diffuse lupus nephritis, where more than 50% of the glomeruli are affected. Class 5 is membranous, and class 6 is advanced sclerosing lupus nephritis. Under class 3 and 4, there are some subcategories depending on the activity and the chronicity of the lesions. We assess the activity of lupus nephritis with different indicators, such as the presence of cellular proliferations, presence of necrosis, cardiorexis, cellular crescents, wire loops, hyaline thrombi, leukocyte infiltration, and presence of interstitial infiltration. There are also chronicity indicators manifested by glomerulosclerosis, presence of fibrous crescents, or interstitial fibrosis and tubular atrophy. And the treatment usually depends on the activity and chronicity indices. There are certain risk factors that lead to progression of lupus nephritis, and these are elevated serum creatinine at the time of diagnosis, the presence of hypertension, the presence of nephrotic angioproteinuria, the presence of anemia, certain ethnicities like blacks and Hispanics, the presence of severity of tubulointerstitial disease and the crescent formation, and the frequency and severity of relapses, and again, male gender is considered a risk factor for progression. In our renal biopsy series from around 13 years ago at the Dahran Health Center, we looked at the causes of secondary renal pathology. And in our series, lupus nephritis was the most common cause of secondary renal pathology in our series, making around 1/3 of all pathologies. So now I will switch gear and talk to you about treatment of lupus nephritis. The goals of the treatment of lupus nephritis are several. First of all, we need to preserve the renal function long term. We need to prevent flares and to avoid treatment harm. And of course, we have to concentrate on improvement of quality of life and patient survival. The treatment of lupus nephritis could be categorized into 2 categories. The first one is an adjunctive treatment, i.e. non-specific treatment, using certain agents like anti-malarials, hydroxychloroquine, use of anti-proteinuric agents, use of lipid-lowering agents, mainly statins, control of hypertension with a goal of 130 or less systolic and 80 or less diastolic, and the use of antiplatelet agents and anticoagulants in patients with antiphospholipid syndrome. The other category of treatment is immunosuppressive treatment. And this treatment is reserved for patients who have proliferative lupus nephritis, i.e. class 3 and class 4, in addition to certain class 5 lupus nephritis. And the treatment with immunosuppression could be classified into two classes. The first phase is induction therapy, and the other phase is maintenance therapy, which is a long-term therapy. Back in the 80s, in the 1980s, the NIH, they conducted a study looking at prednisone compared with azathioprine plus prednisone and compared to monthly IV cyclophosphamide. And that was a large study, and they have found that the prednisone alone regimen leads to a 10 years renal survival of only 20%. However, when prednisone was combined with azathioprine, the renal survival improved to 60%. But when they used IV cyclophosphamide, the renal survival was much better, was around 90%. So that was the standard of care, IV cyclophosphamide monthly for 6 months, followed by quarterly for another 2 years. So that was the standard of care that most people did until to year 2000, when a group from Hong Kong published a randomized controlled studies looking at the role of mycophenolate mofetil in the treatment of diffuse proliferative lupus nephritis, and they compared this regimen with IV cyclophosphamide. So the group 1 received prednisone and mycophenolate mofetil for 12 months, and the group 2, they received cyclophosphamide using the INH protocol, but limited to only 6 months, followed by prednisone and azathioprine for additional 6 months. So both groups were very well matched, though it was only a small study, enrolling only 42 patients, but it was very well conducted. Both groups, the MMF and cyclophosphamide groups, were very well matched. And the outcome they looked at was urinary protein excretion, urinary sediment, serum albumin concentration, serum creatinine, and creatinine clearance. And the result of this study was very positive. They concluded in this trial that treatment of diffuse proliferative lupus nephritis, i.e. class 4, using the combination of mycophenolate mofetil and prednisone was as effective as a regimen of cyclophosphamide and prednisolone, followed by azathioprine and prednisolone. And that was a kind of paradigm shift in the way people treated lupus nephritis. So they switched from a very toxic regimen, i.e. IV cyclophosphamide, to a more benign regimen using oral mycophenolate. 12 years later, a joint recommendation by the European League Against Rheumatism, together with the European Renal Association and EDTA, they issued recommendations for the treatment of proliferative lupus nephritis, i.e. class 3 and 4, where they recommended the use of mycophenolate mofetil with a dose of 3 grams per day for 6 months, or myfortic for the same duration, or the use of a less toxic IV cyclophosphamide consisting of a total of 6 doses, 500 milligrams per dose every 2 weeks, for a total of 3 grams. The American College of Rheumatology adopted the same recommendations based on an extensive literature review. So the recommendation was basically mycophenolate mofetil 2 to 3 grams for 6 months, or IV cyclophosphamide, and they gave people the option of either using the NIH protocol, i.e. 500 to 1,000 milligram per square meter body surface area for 6 months, or the Euro-Lupus protocol, i.e. 500 milligrams every 2 weeks for a total of 6 doses. But the important thing about this recommendation by the American College of Rheumatology is that after 6 months, if there is no improvement to either regimen people choose, people should switch. If the regimen was microphenolic mofetil, after 6 months with no improvement, people should switch to IV cyclophosphamide, and vice versa. If there is no improvement with IV cyclophosphamide, people should switch after 6 months to microphenolic mofetil. What about for the class 5 lupus nephritis? The recommendation by the ACR is to use microphenolic mofetil using 2 to 3 grams for 6 months plus prednisone. If there is improvement, the dose of microphenolate should be decreased to 1 to 2 grams. If there is no improvement, the regimen should be switched to IV cyclophosphamide. Until this time, people had the option of maintaining patients with either microphenolate mofetil or azathioprine. But this study that was published in the New England Journal of Medicine in 2011, they compared the efficacy of microphenolate mofetil with azathioprine, and clearly MMF was superior to azathioprine in maintaining remission. And so nowadays, most people, they choose microphenolate mofetil as the preferred agent for maintenance therapy. Unfortunately, over the years, the trend to progression to end-stage renal disease did not change across different ethnicities and across different socio-economic status. So the trend to develop end-stage renal disease remained the same, and that was the disappointment to the medical community. So do we have other agents? Do we have targeted therapy? So as you know, the pathophysiology of lupus nephritis is very complex. Both T cells and B cells are involved in the pathophysiology. And B cells in particular are very important because they are the source of production of antibodies that play a very important role in the disease evolution. And the B cell has multiple surface factors. One of them is the CD20, which is very important in the proliferation and activation of B cells. So is it possible if we could target the CD20, could we influence the disease of SLE and lupus nephritis? So people try to use rituximab, and rituximab is a monoclonal antibody. It is a chimeric monoclonal antibody. With a chimeric, what is meant by chimeric, this is the antibody that we produce in our body. This is an example of IgG molecule. It has 2 portions, the constant region and the variable region. So a chimeric antibody has the human portion, the constant region is the human portion, and the variable portion is of a mouse. So rituximab is a chimeric antibodies against the CD20, and this was studied in a very big study that is called the Lunar study. And the purpose of this study was to evaluate the efficacy and safety of rituximab in a randomized double-blind placebo-controlled phase 3 trial in patients with lupus nephritis treated concomitantly with MMF and corticosteroid. They enrolled 144 patients with class 3 and class 4 I don't want to dwell on the study, but basically this study was negative. So when they looked at the complete renal response or partial renal response, so there was no difference between the rituximab arm and the placebo arm. So people were disappointed because we thought that rituximab would be a magic bullet in the treatment of lupus nephritis, but unfortunately that was not the case. And nowadays, rituximab is only used as a salvage therapy when all the standard treatment have failed. Do we have new treatments? Anti-malaria's hydroxychloroquine has been used for years in the treatment of patients with lupus, with systemic lupus. And the main aim of hydroxychloroquine was actually to minimize the lupus flare and to control symptoms. But a new study that was just like published recently in a meeting showed that hydroxychloroquine actually decreases the amount of proteinuria in patients with lupus nephritis. And that was the case as well with treatment with vitamin D, especially if vitamin D level is maintained above 40. And these are very cheap and readily available drugs. So there are new treatments. The first one is belimumab, and belimumab is a new drug that was approved for the treatment of SLE back in 2011. And belimumab is a humanized monoclonal antibodies. With humanized, I mean the whole molecule is a human except for the hypervariable region. The hypervariable region is the area that is involved in antigen binding. So this is a humanized antibodies directed against a factor that is called the B lymphocyte stimulating factor. And this soluble factor is secreted by the myeloid cells, by the myeloid cells, and it activates the normal B cells. And it activates them to produce the antibodies or normal immunoglobulins. Also, to stimulate the autoreactive B cells that are involved in the autoantibodies production. So belimumab actually it blocks the B lymphocyte stimulating factors, and it induces apoptosis in both the normal B cells as well as the autoreactive B cells. So this drug was studied in a phase 3 clinical trial, and that was published last September in the New England Journal of Medicine. That was a multinational, multi-center randomized double-blind placebo-controlled trial in adults with biopsy-proven active lupus nephritis. They used IV belimumab 10 milligrams per kg every month, plus standard therapy, and the primary endpoint at 2 years was the primary efficacy renal response, defined as a urine protein over creatinine ratio of less than 0.7, or estimated GFR that was no worse than 20% below the value before the renal flare, or greater than 60 ml per minute per 1.73 square meter body surface area. And the major secondary endpoint was a complete renal response, defined by a urine protein over creatinine ratio of less than 0.5, or estimated eGFR that was no worse than 10% below the baseline eGFR. So they enrolled 446 patients. The belimumab arm was 223 patients, while the placebo arm was 223, and the primary endpoint was the primary efficacy renal endpoint. So this is the result of the study. When they looked at the primary efficacy renal endpoint, it was in favor of belimumab. And when they looked at the complete renal response over time and the probability of complete renal response, again, that was in favor of belimumab. So this slide, this summarizes the result of this study. The primary efficacy renal endpoint was better with belimumab, as depicted here in the blue bar. The complete renal response was better with belimumab. The side effects and complications of belimumab were similar to the placebo arm. There was no difference. So another agent that has been, and by the way, now belimumab has been approved only in January this year as a therapeutic agent in the treatment of lupus nephritis. And this is in fact the first time that a drug is approved specifically for the treatment of lupus nephritis. So another drug that has been recently studied, and this is voclosporin. And voclosporin is a calcineurin inhibitor that is a unique agent. It is not similar to tacrolimus and cyclosporin. This drug has a stable pharmacokinetic where you don't have to check the level. So it is a fixed dose, you give it and you forget about the level. It's not like cyclosporin or tacrolimus. So this study was, this drug was studied in the Aurora study, and that was a phase 3 multi-center randomized double-blind placebo-controlled study over 1 year period. And they enrolled patients with class 3, class 4, and class 5 lupus nephritis. And patients were randomized into voclosporin in 1:2 ratio. And they used this dose, 23.7 milligrams BID, in addition to the standard treatment of mycophenolate mofetil 1 gram BID and steroids. The primary endpoint of the study was renal response at 1 year, defined as urine protein over creatinine ratio of less than 0.5 milligram per milligram, or eGFR greater than 60 ml per minute, or no confirmed decrease from baseline in estimated GFR of more than 20%, or the presence of sustained low-dose steroids and no administration of rescue medication. So a total of 357 patients were enrolled, 88% were female, and the median age was 31 years. And they enrolled the patients at high risk, such as Hispanic and Latinos. And that was the summary of the study. At 24 weeks or 6 months, the partial response was better with voclosporin, as depicted here in the blue bar. The complete response at 6 months was better with voclosporin. The partial response at 1 year was better with voclosporin, and the complete response at 1 year was also better. So that was very encouraging. The only problem with these two drugs, we don't know how long we should continue treatment. So I would like to summarize that renal involvement is a major cause of morbidity and hospital admissions in patients with SLE, and it occurs in around 40% to 70% of all patients. Nephrotic and nephrotic syndrome, or both, may be observed in 1/3 of patients. Initiation of immunosuppressive treatment should be guided by a diagnostic renal biopsy. Immunosuppressive agents are recommended in class 3 and class 4 nephritis, and also in class 5 nephritis if the proteinuria exceeds 1 gram per day despite optimal use of RAS blockers. And the treatment should aim for complete renal response with resolution of proteinuria and normalization of GFR, partial renal response of greater than 50% reduction in proteinuria, and normal or near normal renal function should be achieved by 6 months, but no later than the 12th month. If this is not achieved, then the regimen should be switched to another regimen. And new and more specific agents may have a promising role in the future. Here I will stop and thank you for your attention. And I'll be happy to entertain any question. Thank you.
Thank you, Dr. Ahmed Ckd. Was an interesting, very rich presentation. I'm sure there will be a lot of questions raised. Before we take the questions, this is a good offer for all the audience. This is a good offer from Mawadi. There will be a code sent to everybody, and they can use the application for free for 1 month consultation. So this is يعني زي ايش هدايا رمضان هذه. You can use the code. And I welcome all the 136 participants. I believe Dr. Mohammed Ghunaim, he has to leave for other commitments. So we'll start having questions regarding, we'll focus on the presentation. We had a question here about lupus, and I think, yes, this question from Abdulrahim Maulana, will the lupus nephritis affect the transplanted kidney? That's a smart question. So Dr. Ahmed Ckd, please.
Yeah, when people looked at the recurrence of lupus nephritis in the kidney graft, it looks like it is very minimal. So ideally, patients with lupus nephritis should not proceed for kidney transplantation until the disease is quiescent. And usually the disease burns out once people develop end-stage renal disease and it becomes really inactive. So the risk of recurrence is very small, and bear in mind that patients who are a kidney transplant recipient, they are maintained on a long-term or lifelong, actually, immunosuppression. So that by itself suppresses any lupus activity. So rarely patients with lupus nephritis who go for kidney transplant, they rarely develop lupus flare. So basically, the short answer, the recurrence is very rare, and it is not a concern at all.
Okay, thank you. Also, would like to announce that the presentation or the whole conference will be recorded and will be posted in actually now live in YouTube, and will be in YouTube. So anybody who are interested, they can revisit the presentation or anything that are missed or not clear. You can go to the YouTube and see the whole presentation, the whole conferences. Okay, next question, we have a couple of questions from Salwa. Salwa is asking about MMF is only treat the class 4 lupus nephritis as a maintenance. Is it only for maintenance? Yeah, the MMF.
So MMF is probably the best drug for maintenance therapy. So I told you, in 2012, the American College of Rheumatology gave the people the option of using either MMF or azathioprine for maintenance therapy. But the study that I quoted, that was published in the New England Journal of Medicine in 2011, clearly demonstrated that MMF is a better agent for maintenance therapy compared to azathioprine. So I think the standard of care until now for maintenance therapy should be MMF.
طيب. Also, another question by Dr. Salwa Al-Hamaidi, if I pronounced it right. Is the treatment of lupus nephritis is the same post-transplant, or there is difference? I think you answered this, but maybe you can.
Yeah, as I said earlier, we rarely encounter lupus nephritis and post-kidney transplant for two reasons. The disease has become quiescent when people develop end-stage renal disease, i.e. it was not active anymore. And the other thing is that these patients are maintained on lifelong immunosuppression, which would suppress any disease activity.
A question from Hashim Al-Miqdad. What about focal supporine indication in lupus nephritis? COVID vaccine is, we put two questions also about COVID vaccine. So can we take the first part?
I'm sorry, could you repeat
I think Mrs. spelled focalosporin indication.
Voclosporin, okay.
Yes.
The study, the Aurora study, actually, they used voclosporin together with the usual treatment. So it was an addition to the usual regimen. So the indication was to use it in patients with proliferative lupus nephritis, i.e. class 3 and 4, in addition to membranous lupus nephritis, i.e. class 5.
Okay, maybe this is the last question. Is there any future plan for gene therapy in management of lupus nephritis?
Yeah, everything is possible when it comes to gene, but now people are looking at the spectrum of proteins that are excreted in the urine of people with lupus nephritis. So the proteomics of the proteinuria is different across the patient spectrum. So when people look at certain cytokines that are excreted in the urine of patients with lupus nephritis, they have found out that IL-16 is a very important prognostic factor in the progression of lupus nephritis. People may actually target certain cytokines such as IL-16 as a possible treatment. Gene therapy is the future for many diseases, and I cannot exclude lupus or lupus nephritis.
Okay, I think we're done with the questions, and we covered a good amount of questions and discussions. And before we end and go for break, I would like to thank our previous speaker, previously Dr. Bishr Al-Attar and Dr. Ahmed Al-Khanezi, and our co-moderator, co-chair, Dr. Muhammad Ghunaim, who had to leave for other commitments. So we'll break for prayer for 15 minutes. We have a good time, so we can break for 15 minutes and we reconvene after 15 minutes, and we'll take the next presentation. Okay, thank you everybody, and see you in 15 minutes.
dear doctors, to break it out.
Assalamu alaikum, everybody. Let's start our second session on the first day. And according to our schedule, we have 3 lectures in this second session. The first one will be delivered by Dr. Abdulrazak Amir. As mentioned by Dr. Hanan earlier, that for emergency reason, we wish him the best. He joined his father for health issue, but he gave a wonderful presentation. I'm looking forward to hear about diabetic kidney disease, epidemic of diabetic kidney disease. This one is recorded by Dr. Abdulrazak Amir. He is consultant nephrologist working at the John Hopkins Aramco Hospital.
Good afternoon, ladies and gentlemen, and thank you very much for attending this special session about epidemic of diabetic kidney disease. I'm delighted to present to you the latest data about the burden of disease of diabetes in the world. My outlines of my presentation will include the prevalence of diabetes and the global economical burden, And we're going to talk also specifically about the prevalence of diabetic kidney disease. We're going to touch base on the screening and diagnostic modalities for patients with diabetic kidney disease. And in the final few slides, I'm going to touch base on the prevention and some treatment methodology for patients with diabetic kidney disease. So let me introduce you to the International Diabetic Federation Atlas, which is published every 2 years. The authority here actually provide this resourceful information about diabetes to all healthcare professional, academic, and policymakers to alert them about the burden of diabetes in the world. And they published their first publication about this data was in year 2000. And since then, every year it gets revised and new data is published to the scientific community. There's a group of scientific committee who actually sit on board and represent the 7 continents presented in different colors in this graphic slide. The blue represent Europe, the green represent the North America and Caribbean, the light blue represent the South and Central America, the orange represent our region, the Eastern Province, the Middle East and the North America, and the pink color or the maroon color represent Africa, and then we have the Indian continent in red, and then we have in purple the part of Asia, which is the Western Pacific Asia region, including China and Australia, Japan, Malaysia, and Indonesia. Let me take you and make you understand this particular slide. If you zoom on the orange part of the map, which represent the Middle East and the North Africa, you realize that the number of the patients who actually diagnosed to have diabetes in year 2017 were about 39 million. And it was projected that by year 2045, the number will rise by 110% to 82 million. In contrary, countries like, continent like Africa, the number of diabetic patients are quite low in comparison to the rest of the world. There are only 16 million diabetic patients in the southern part of Africa. However, this number expected to rise significantly by 156% by year 2045. So globally, it is expected that by year 2045, the number of the patient with diabetes will increase to 629 million, which is almost 48% more than the current value. Well, let me stop here for a second, because these are the data by IDF, which were published in 2017 on their 8th edition. However, their 9th edition actually projected much higher number of diabetes in the world. So they are anticipating more than 700,000 patients with diabetes by year 2045. This slide represents a very important aspect of diabetes prevalence. The Middle East and the North part of Africa, as you can see, have the highest age-adjusted prevalence of diabetes in adults in 2019, 2030, and also in projected figure in 2045. However, the Africa, as I mentioned, the Africa region has the lowest age-adjusted prevalence in 2019. And the thought behind this is that the lack of urbanization and the undernutrition and the lower level of the overweight and obesity among African patients. So what is the prevalence of diabetes? Prepare yourself for a very disturbing numbers. Well, we know that type 2 diabetes is the most prevalent in the world. Actually, 91% of the adults with diabetes are of type 2. However, we don't know that actually there is more than 230 million people with diabetes who are actually undiagnosed, so 1 in 2. And 1 in 13 adults have impaired glucose tolerance, and 1 in 6 live births, which is about 20 million live births, are affected by hyperglycemia in pregnancy, particularly gestational diabetes. So in year 2015, 1 in 11 adults are diabetic, and it is anticipated by 2040 that the number will be much more. So 1 in 10 adults will have diabetes. The data from the WHO Observatory Data Repository from 2013 reflected that the death and the fatality from diabetes far exceed the fatality from HIV, tuberculosis, and malaria combined. About 5 million adults under the age of 60 are actually, they die every year because of diabetes and its complication. The other thing of importance that diabetes has a very create a large financial burden on individual and their families in the cost of medical care, including medications, equipments, particular cares, and not only that, it also have a substantial economical impact on countries and national health systems. So this is the data about expenditures, the spending on a diabetic patient in 2015. It was about $650 billion globally, and this number actually is expected to increase by year 2040 to almost $800 billion, which is an increment increase of 19%. And this is in correlation with the increase of number of cases of diabetes by 35% by year 2040. So if we look at the reason of hospitalization among diabetic patients, you'll find out that diabetic patient 6 to 12 times more likely to be hospitalized for chronic kidney disease and in the stage renal failure. And this is very disturbing. And if you look at the prevalence of diabetes by age and gender, you also notice that diabetes grow with age. It peaks around the age of 50 to 70, and male to female are more or less equal. The prevalence of this disease among male and female, a bit more in the male gender, but it's more or less abundant among both genders. If we look at the top 10 countries in the world where adults with diabetes between the age of 20 and to 79 years are prevalent, you'll find that the top 10 countries include China, India, United States, Brazil, Mexico, Indonesia, Russia, Egypt, Germany, and Pakistan. And if you look at the expenditures, 69% of the global healthcare expenditures on diabetes are paid or spent by these 10 countries only. So what about Saudi Arabia? Well, these are the data from Duweish, which was published in 2016. This data reflected that the WHO reported that Saudi Arabia considered to be the second highest in the Middle East when it comes to the number of diabetic patients, and the 7th in the world for the rate of diabetes. We have 7 million of our population are diabetic, and another 3 million are pre-diabetic. And the problem here is that over the last 3 years or so, there has been a significant increase by tenfold in the prevalence of diabetes. So how we can classify diabetes? Well, diabetes, as we know, is a group of disorders having in common hyperglycemia. Type 1 diabetes is a medical entity where there's an absolute deficiency of insulin, happen mainly in children. And type 2 diabetes mellitus, which actually there is somehow relative deficiency of insulin, predominantly related to insulin resistance or even deficiency. And then we have the gestational diabetes, and we have other type of diabetes which are of genetic forms or related to medication. So what is the diagnostic criteria for diabetes? Well, to be called diabetic, you have to have a fasting blood sugar of more than 126 milligram per deciliter, or 2-hour glucose postprandial of more than 200 milligram per deciliter, or a random glucose of more than 200 plus a hemoglobin, or hemoglobin A1C of 6.5%, more than 6.5%. And then we have the impaired glucose tolerance, where the fasting blood sugar is high. However, the postprandial blood sugar is less than 200. And then we have the impaired fasting glucose, where the fasting blood sugar anywhere between 110 to 125 milligram per deciliter. However, their 2-hour glucose postprandial is less than 140. So how we can diagnose the entity of prediabetes? Well, it is diagnosed by a fasting blood plasma glucose of 110 to 125. We call it IFG, which is the impaired fasting glucose, or those who have 2-hour post glucose load of more than 140 to less than 200, and these are the IGT, which are the impaired glucose. And then we have the A1C, which is between 5.7 to 6.4, and we call them pre-diabetics. The A1C level and future risk of diabetes. This is very interesting. A study by Zhang. He actually looked at he did a systemic review, and he looked at the 5-year incidence of diabetes in comparison in relation to the A1C level. And he found out that a level between 6 and 6.5 would increase your risk of developing diabetes from 25 to 50% in 5 years' time. So even a little increase in the A1C level would increase the risk of development of diabetes in the pre-diabetic population significantly. Looking at the glycemic threshold for development of diabetic retinopathy, and this is a very important study from Australia and Sydney, and they looked at the data pooling analysis of 9 studies from 5 countries with almost 44,000 participants involved in this study. They found that when diabetes-specific retinopathy was plotted against a continuous glycemic measure, a curvilinear relationship, so this is the curvilinear relationship, was observed for fasting blood sugar and A1C. And diabetes-specific retinopathy prevalence was low when the fasting blood sugar was less than 6.0 millimole, the hemoglobin A1C was less than 6.5 millimole. So this is very important because so patients who have hemoglobin A1C less than 6, they had no or less retinopathy event, while those who had more than 6.5, they actually had more retinopathy event. The risk factor for developing of diabetes, as we know, as I said earlier, age, having a first-degree relative with type 2 diabetes. Interestingly, in the Canadian CPG diabetic recommendation, they put Arabs actually as a higher risk population for development of diabetes. And I think that I explained that on the first map slide that I showed you earlier. The presence of pre-diabetes is also very important. And of course, having history of diabetic glucose intolerance is also important. So what is the etiology? We look at diabetes and its diabetic kidney disease. We realize that in Saudi Arabia, this is the data from the SCOT 2018. The total number of patients who actually with end-stage renal disease were about 18,000. 39% of them, the underlying etiology of ESRD was diabetic nephropathy, and 36% were hypertensive nephrosclerosis. Our data and our statistics are quite similar to the world. This is the data from the USRD, which again showed that diabetes mellitus contribute to almost 40 to 45% of the total cases of end-stage renal disease in the United States. And similar finding also was noted in the Canadian region, where diabetes is the primary cause of end-stage renal disease in their country. So how we define diabetic kidney disease? Well, diabetic kidney disease is a medical entity where there's a progressive increase in the proteinuria in people with long-standing diabetes, followed by declining function, which can eventually lead to end-stage renal disease. So to make up the diagnosis, you either have albumin-creatinine ratio more than 300 milligram per gram, what we call macroalbuminuria, although the term macroalbuminuria is no longer used. The albumin-creatinine ratio 30 to 300 milligram, which means that the patient have macroalbuminuria, plus the presence of retinopathy in a patient who have type 1 diabetes for more than 10 years. And the other characteristic feature of this disease is progressive albuminuria and hypertension with decline in the GFR in patients who have long-standing diabetes mellitus. As we know all, as a nephrologist, we don't recommend and we don't do kidney biopsies for these patients, except in a very rare circumstances where there's suspicion of having underlying concomitant glomerular disease or other medical entities, renal entities, which actually causing the patient renal dysfunction and the proteinuria. I'm not going to spend more time on the stages of nephropathy, but just for our junior fellows and residents, well, the process starts early on, what we call it the pre-nephropathy stage, where actually there is an increase in the GFR, and this is the hyperfiltration time. And this happened around 5 years of having diabetes. At this stage, there's not much of protein. The urine diabetic is negative, and there's not much of protein in the urine. And then we have the incipient diabetic nephropathy, where there's what we call it where the macroalbuminuria start to come. And still, the urine diabetic will not capture this. But if you do the 24-hour urine for albumin or albumin-creatinine ratio in a random sample, then you can detect the albuminuria. And with that, there will be a gradual worsening or decline in the GFR of the patient and kidney function. And there will be more proteinuria. Hypertension also happens at this stage, and the patient will develop CKD5 or end-stage renal disease in 20-25 years down the road. So I want to mention something about the screening for patients with suspected diabetic nephropathy or diabetic kidney disease. Well, this is from the data from the Canadian Institute of Health Information. And they found out among the family medicine practitioners that when it comes to looking after a patient with diabetes, urine protein creatinine ratio was not one of the top things that they were doing for their diabetic patient. Only 74% of the patient had urine protein tested, when compared to hemoglobin A1C, which was checked almost in 81% of the patient. So why we treat diabetes? Well, we want to prevent short-term serious complication like ketoacidosis and hyperosmolar syndrome. And of course, we want to prevent long-term complication, micro and macrovascular complication. And of course, remember that even those who do not have the micro and the macrovascular complication, we want to make them happy and feel better. The polyuria is very disturbing for people to sleep. They don't feel well with that. There's always an element of fatigability and depression, which are always reversible once the good glycemic control is achieved. Let me show you the significance of proteinuria on cardiovascular and cerebrovascular events. This is a very old study by Mittinen, which was published in 1996. And again, they looked at 3 groups of patients, those who have mild proteinuria, almost microalbuminuria, and those who have offered proteinuria in blue color, the C line. If you look at the incidence of a stroke and coronary event, they were much higher among patients who actually have heavy proteinuria. So how we can reduce the progression of diabetic nephropathy? There is 4 elements for this. The first one is a good glycemic control, since diabetes is the culprit and the cause of the problem. The second thing is a good blood pressure control. And then we have a dietary control, talking about salt and low protein animal protein diet. And then the use of antiproteinuric agent, ACE inhibitors, ARBs, or even non-dihydroprotein calcium channel blockers. I want to show you here this very important study, which is the DPP study, which had almost 3,234 patients with different pre-diabetic, which were all pre-diabetic. They randomized them into those who actually took metformin, and those who actually, metformin means 850 twice a day, or lifestyle modification. And the lifestyle modification recommended at least 7% weight loss and at least 150 minutes of physical activity per week. And guess what? Lifestyle modification had a better value, in a sense that it reduced the risk of developing diabetes by 58% compared to metformin, a good dose of metformin, 850 BID. So the lifestyle modification, reducing the weight as well as exercising, did miracle more than medications. How about protein intake? Well, this is a very basic study which looked at a patient with diabetes, and they randomized them into a usual protein diet, 1 gram per kilo, and those who actually received 0.8 gram per kilo. And they were looking at the prognosis and development of end-stage renal disease and death in type 1 diabetes. And of course, patients who actually received reduced protein diet, they have less endpoints when compared to those who actually received the usual diet. How about the salt intake? Well, salt is a miracle, and I think we have to emphasize a low salt diet among all our patients, whether they are hypertensive or even diabetic. And this is a very simple study done comparing the role of dietary sodium restriction in patients who actually given ACE inhibitor versus those who actually received dual blockage by ACE and ARBs. And you can see here that patients who actually received low sodium diet, they have tremendous reduction in the degree of proteinuria, whether they were on ACE alone or in combination therapy. Again, this is a multi-center study done among non-diabetic nephropathy. So prevention of diabetes, the optimal glycemic control have to be achieved, and and it's shown that it reduced the development of progression of nephropathy, retinopathy, and other macrovascular complications. So what is the typical glycemic control recommended? Well, I would say for most of the patient, 7% is ideal. However, patients who have chronic kidney disease or those who have a risk of developing retinopathy, less than 6.5 is okay, as long as they don't have risk of developing hypoglycemia. Then we have a liberal group where the hemoglobin A1C anywhere between 7 and 8.5. And these are the frail adults and those who are actually terminal and old group of patients who have multiple comorbid medical conditions. We cannot do a tight control. The study, which is well known, the Ckd trial, when they tried to do a very tight control on the blood sugar by reducing hemoglobin A1C to 6%, there was a significant rise in the cases of CHF, coronary artery disease, MIs, and other cardiac morbidities. So a tighter control, less than 6.5, is really not recommended. So why we do treat diabetes? The two famous studies, the DCC trial and the Ckd trials, have shown clearly that a good hemoglobin A1C reduction reduces retinopathy, neuropathy, macroalbuminuria. This was documented in type 1 and type 2 in the DCC trial, as well as the Komodo and Ckd trials. And we have also something we call it the legacy effect, which is basically even after we stop the intensive control of hemoglobin A1C by 5 years in this particular trial, there was a beneficial effect continued 5 years after stopping the intensive treatment. So even a little reduction in hemoglobin A1C by 2% have reduced the risk of retinopathy by 76%. So I'm going to move on quickly just because of the time. The question comes like, is the diabetic nephropathy or diabetic kidney disease is reversible? This is a beautiful paper where a patient with diabetes, type 1 diabetes, underwent pancreas transplantation. And you can see here, this is the GFR and this is the tubular basement membrane. I'm sorry, this is the tubular basement membrane and this is tubular basement membrane. Structure and thickness was measured over time, 5 years, 10 years, and you can see there is remarkable normalization of the pathology which happened earlier by diabetic nephropathy when the patient prior to the transplant and 5 and 10 years down the road. And these are the classic Kimmel-Still-Wilson nodules shown at the time of the transplant and down the road, 10 years down the road when everything resolved. And as you can see, the glomeruli, there's minimum mesangial expansion and maybe focusing mental changes, but not as terrible as it was before. So what is the role of RAS in progression of chronic kidney disease? We know that when the renal function drop, there is increase in the RAS activity, which will cause hypertension. There will be efferent arteriolar constriction, which will increase the glomerular hypertension. There will be release of growth factors, which will cause mesangial cell proliferation. And there will be also release of certain cytokines and pro-inflammatory mediators. Eventually, it will lead to more glomerular damage, and this will also a vicious cycle will decrease renal function and so on. So the ACE inhibitors have proven with no doubt that they can reduce the proteinuria. This is a very early study done in 1995 with captopril. And a similar finding has been done with the newer agent from the ARBS group. And does the combination of ACE and ARBS safe? Well, the on-target trial have changed the practice. We used to give ACE and ARBS before, but after this trial, there was, as you can see, there was no difference in the cardiovascular event, but more side effect was noted in the form of hyperkalemia and acute kidney injury. So we don't recommend combination therapy. How about giving supramaximal doses of medication? Well, this is from the candesartan trial, which actually given more of the medication. We know that candesartan comes at 8, 6, 16, and 32. But if you give a supra dose of 64 and 128, you can get more proteinuric reduction. The way I give antihypertensive medication, of course, our target here is to reduce the blood pressure to 125 over 75 in patients with chronic kidney disease. We have first strategy is to give drug 1, and if it's not at goal, the blood pressure is not at goal, you titrate it to max, and then if it's not at goal, you add another medicine, and so on. Or you can start strategy B, where you can start with combination 2 drugs and then titrate both drug to max, and then if it's not working, you add a third drug. Or the strategy C, where you start patient in 2 drugs and you don't titrate them. If the patient is not at goal, you just add a third drug. What about use of calcium channel blocker? Well, the calcium channel blocker, the non-dihydropyridine calcium channel blocker like diltiazem and verapamil, are actually good drugs to be used in combination with the ACE or ARBS if your proteinuria is not well controlled. So this is a very early study published in KI by George Pickers. And you can see here that the reduction of proteinuria was significant with non-dihydropyridine. On contrary, patients with dihydropyridine, such as nifedipine, actually have more proteinuria. The use of metformin and renal dosing, no longer we are looking at serum creatinine. The FDA modified labeling in 2016, and now we're using the eGFR. You have to play it case by case. How about the newer agent, the SGLT2 receptor blocker? Inhibitor. Our sodium glucose co-transporter inhibitor. They are a marvelous drug. They have this is the mode of action. They actually adjust the intraglomerular pressure, reduce it, and by this they stabilize the eGFR and reduce albuminuria. Therefore, there's so many studies have been done, and all in favor of using this agent. They have reduced the tendency of worsening renal function, maintained the GFR, reduced proteinuria, delayed the initiation of renal replacement therapy, and so forth. I'm not going to spend more time on this because of the time limitation I have. For my colleague in primary care and family medicine, when you should refer patient to nephrologist. Well, if you have somebody with chronic renal function, it's progressive. Usually, we like to see them when the GFR is around 30s, like a stage 3. If the albumin creatinine ratio persistently more than 60, if the eGFR less than 30, and if you have suspected that the patient have another renal entity that need to be treated, or the presence of side effects of medications or acid-base disorders that need nephrology attention. Of course, management of hypertension is also important. So the take-home message from this presentation is diabetic kidney disease is the leading cause of end-stage disease in the world. It has a huge economical burden in all the countries. Diabetic nephropathy is preceded by the onset of proteinuria. Proteinuria and impaired renal function are a strong predictor of developing renal failure, cardiovascular morbidity and mortality. Glycemic control and blood pressure control help to reduce development of progression of chronic kidney disease and diabetic kidney disease. ACE and angiotensin receptor blockers are useful in diabetic nephropathy, and you could add, of course, the newer agent SGL2 inhibitors and adjust your medication therefore. Thank you for listening.
Assalamu alaikum. We heard a very exceptional, nice presentation from Dr. Abdulrazak Amir. Unfortunately, he is not with us in person. We'll not have a discussion right now. We'll defer discussion to the end of this session because of the time concern. And I will move to the next presentation. The next presentation by Dr. Mettab El-Bugumi. And the title of his presentation is COVID-19 in transplant patients. So this is extremely hot topic. So Dr. Mettab, head of adult kidney transplant section in King Fahad Specialist Hospital. Thank you for sharing with us your knowledge and expertise and your time, of course, at this time of the day. And I'm sure that we will enjoy an exceptional presentation that will raise a lot of questions. So mic is yours, Dr. Mettab.
Thank you, Dr. Hanan. Assalamu alaikum. Good evening, everybody. First of all, I'd like to thank Ethar and Scott for their kind invitation. As Dr. Hanan mentioned, I'll share some of our experience in our hospital, King Fahd Specialist Hospital, and other hospitals in the country with COVID-19 patients. As you know, we lived quite a year in 2020. The first case of COVID-19 was diagnosed in December 2019 in China, and it was a matter of a few weeks until the disease became a pandemic. It basically crossed all the borders and affected all the regions globally. This time last year, I think everybody remembers very well that we were living the lockdowns and all kind of restrictions before the holy month of Ramadan. When we talk about numbers, these numbers were taken by the end of first week of April. All over the world, there were about 133 million cases of COVID with 2.9 mortalities. Saudi Arabia's, we are approaching 400,000. It's about 394,000 with 6,700 mortalities, a mortality rate of 1.7%. As all of you know, renal transplant patients are quite vulnerable because of their immunosuppressed status. So they are at risk of different variable or a wide range of complications, whether infectious or non-infectious. They are in particular more susceptible to have infection with RNA respiratory viruses. COVID-19 is one of them. And also they are at high risk of having secondary infection or superinfection. So once they are infected with these respiratory viruses, they are at risk of having bacterial or fungal secondary or superinfections. As you can tell, everybody is prone to have COVID-19, but there are certain risk groups that are prone to have severe COVID-19s. These groups include advanced age, people with age of 65 and above, obesity, having chronic diseases like diabetes, lung diseases, and cardiovascular disease. And the specific group that we are talking about, the immunocompromised patients. And guess what? Most of our kidney transplant patients have some of these previously mentioned complications. They are more likely to be diabetic, obese, and having underlying chronic diseases. When we look at the epidemiology of COVID-19 across the kidney transplant patients, I would like just to draw your attention to this part of the table. Multiple observational studies have been published. The column here represents the number of participants, and the second one is basically the incidence of COVID-19 in renal transplant patients. So as you can see, there is a quite variation with an incidence rate ranging from 8.3 up to 234 per 1,000. The reason for this quite variation is the targeted group. So during the first wave or the initial months of the pandemic, all the world were focusing on patients with the symptoms. So the studies that were targeting symptomatic renal transplant patients showed an incidence rate of 8.3 up to 18.5. Including asymptomatic patients, raised that incidence to about 40 to 55. And the last study was done in New York, and they basically combined the use of the PCR as well as the antibodies. And the incident rate was 234 per 1,000. So just to remind everybody, New York had a very bad wave of COVID. And those with negative PCR, however, positive antibody detection was about 48% in this particular study. When we compare the incidence or the risk of having COVID-19 in transplant patients to the general population, they are at 2 to 5 times risk of having COVID-19. The hospital admission is ranging from 80 to 100%. Basically, during the first months of the pandemic, we were even at our hospital cautious about these patients, and we were admitting them. Later on, a good number of patients could be managed as an outpatient. This might explain the variation in the percentage of hospital admission. When we talk about acute kidney injury in patients with COVID-19, and here we're talking about the general population, multiple studies were done. However, one large cohort of about almost 10,000 individuals showed that AKI developed in 40% of the cohort. So 40% of patients with COVID-19 are at risk of developing AKI. 6.6% required some sort of renal replacement therapy, and 1/3 of these patients, those who developed AKI, didn't have full recovery of their renal function. So it's a quite devastating disease that also involves the kidney. Multiple risk factors have been identified and linked to increasing the risk of developing AKI among COVID-19 infected patients, including advanced age, being a male, having diabetes, the underlying respiratory impairment, the severity of the lung disease, requiring mechanical ventilation, the presence of pre-existing chronic kidney disease, and also confliction with other organisms, and the presence of systemic inflammatory response. What about patients with renal transplants? So infected renal transplant patients had a higher risk of developing AKI. In this table, we see multiple studies with the number of patients giving us a weighted average of 45.7% with the need of renal replacement therapy of 10%. When we compare them to the general population, the risk is slightly higher. However, the need of renal replacement therapy is significantly higher. One particular study looked at 19 articles that reported acute kidney injury incidence among the renal transplant patients and non-renal transplant patients. They basically did some comparison. The AKI incidence was higher in the renal transplant patients, was about 27% compared to 13% in the non-kidney transplant patients. Also, the need for renal replacement therapy was higher in the transplant patients, 15% compared to 3%. However, the mortality rate was similar between the transplant and the non-transplant group. ARDS is a major complication of developing COVID-19, and I'm sure everybody remembers what happened in certain area of the world, and also some area in our country where ICU beds were filled with ARDS patients. Kidney transplant patients were more likely to develop ARDS if they develop COVID-19 compared to the general population. If we look at the average, weighted average, it's about 41% compared to 21%. Certain risk factors were linked to developing ARDS in patients with kidney transplant or kidney transplant recipients. Obesity was a major risk of developing ARDS. Higher level of LDH at presentation, and there was a trend of linking higher risk of developing ARDS in patients on tacrolimus-based regimen. Mortality in kidney transplant patients with COVID-19 is higher compared to the general population. However, it was quite variable based on multiple studies. So the range was reported to be anywhere between 18% and 43% in different studies, about 20 different studies from multiple countries. There were multiple risk factors that have been associated with mortality in renal transplant patients with COVID-19. If we look at these or this table, age being above 60 is linked to a higher risk of mortality if a kidney transplant patient developed COVID. Male gender is a risk factor. If someone was treated for rejection recently within the last few months of developing COVID, that was a risk. An interesting finding also, being on cyclosporin seemed to have a protective effect or a survival advantage when compared to other immunosuppressive regimen. Development of nosocomial COVID-19, someone developed the infection within the hospital, was linked to a risk factor of mortality. Having dyspnea on presentation is linked to higher rate of mortality. Any GI symptoms seem to be protective to mortality. So diarrhea at onset was associated with the lower risk of mortality. Multiple other laboratory markers, as well as elevated GFR on presentation, was linked to the higher mortality. And as you can tell, having underlying chronic diseases such as cardiovascular disease and diabetes. So what we've done in our center, we conducted, actually it's not only our center, it was a multi-center retrospective study where all the kidney transplant patient recipient with the SARS-CoV-2 infection, COVID-19, were enrolled. The study period was from the 1st of March until the 31st of July 2020. Multiple centers involved: King Fahd Specialist Hospital, National Guard in Riyadh, King Abdullah Medical City in Mecca, King Fahd Hospital in Hafuf, and Al Hada Military Hospital in Taif. Patients enrolled, if they are adults 18 and above, they need to have symptoms compatible with COVID-19 plus having positive PCR. And also, if they are asymptomatic, identified during contact screening with an infected COVID-19 patient plus positive PCR, they were also enrolled in the study. The management plan for patients was based on a homemade clinical management protocol because we collected data from multiple sources: Waqaya, was paramount for building up this protocol. However, some details related to immunocompromised and kidney transplant patients in particular were extrapolated from other guidelines. So basically, that protocol talked about certain risk stratification strategies. Basically, patients could be managed either as an outpatient or inpatient. And also talked about the management, general guidance, basically how patients should isolate themselves and the general precaution we all know about, what to do in terms of laboratory and radiological tests, how to handle the immunosuppressive medication, what antimicrobial to use, and the role of anticoagulant therapy and plasma exchange. Certain demographic, clinical, lab data were collected, as well as data related to the treatment regimen used and the outcomes of the patients. So those who were not admitted to the hospital had been followed closely on a daily basis by dedicated coordinators and transplant nephrologists utilizing virtual clinics. So the total number of patients were 130. 71 of them were admitted. It's about 55%, while the remaining 59 were managed as an outpatient. 40% were females, and the average age was 49 years. As we heard from the previous lecture, diabetes would be the most common cause of end-stage renal disease, representing a third of the cohort. Hypertension and glomerulonephritis came second. We are a country that heavily dependent on living donation, so 80% of the transplant were living donor kidney transplants, and the remaining 20 were deceased donor kidney transplant. We are not different than most of the world. We are tacrolimus, MMF-based immunosuppressive regimen. So most of the patients, as you can see, were in tacrolimus, steroids, and MMF. 2 patients developed acute rejection 3 months prior to having COVID, and one of them received thymoglobulin to treat that rejection. The comorbidities are shown here. Diabetes, hypertension, and obesity were the commonest, and as you can see, they were actually more commonly seen in admitted patients compared to those managed as an outpatient. Clinical presentation was fever, respiratory symptoms, and some GI symptoms. Fever was the commonest, seen in 60% of the patients, and also was one of the commonest reasons to admit patient to the hospitals, as well as respiratory symptoms. Upon tracking the source of COVID, 60% of the patients reported family member having COVID-19 just before diagnosing the transplant recipient. 43 patients, about 1/3 of the cohort, had abnormal chest X-ray on admission, and as you can see, all of them were admitted. So I think we had a low threshold to admit patients. So anyone with abnormal chest X-ray at presentation was admitted during the study period. So 43 patients had an abnormal chest X-ray. However, I mentioned 71 patient was managed as an outpatient. 71 patient was admitted in hospital, so hospitalized for further management of COVID-19. 28 of the 71 needed ICU admission. 18 of the 28 needed mechanical ventilation, and 14 of the 28 required vasopressors. So 71 admitted, about 40% of them admitted to the ICU, more than 50, but 2/3 of them, of the patients admitted to the ICU, needed mechanical ventilation, and 50% required inotropic support. Upon presentation, the median WBC was normal at 5.4, however, with low absolute lymphocyte count and percentage of lymphocytic count. Creatinine at presentation was slightly elevated at 99. If we could also consider it a normal creatinine at presentation between the outpatient and the inpatient. C-reactive protein, D-dimer, and procalcitonin were elevated among those who were admitted. So when we look at the management of such patient, the first thing we've done was basically holding mycophenolate for about 88% of the patient, but you can see it went up to almost 96% among those who were admitted. Tacrolimus was reduced mainly if the patient is admitted, and steroids were shifted to hydrocortisone or methylprednisolone, sorry, dexamethasone for those who were admitted. When we look at the regimen that's used, we could see a cocktail of medication. And basically, when we see a list like this, we know for sure that none of them is really working very well. Hydroxychloroquine was given in 15 patients, which is really something I'm proud of, because if you remember that time we were distributing hydroxychloroquine for everybody, even in the primary healthcare clinics. Although there was no evidence that it has anything to do with with COVID-19, and even after that, the studies showed no evidence of using hydroxychloroquine. So 15 patients received hydroxychloroquine. Azithromycin was used in 40 patients. Tocilizumab was used in 7 patients, basically in inpatient setting, and favipiravir was used in 20% of the cohort. 7 individuals were sick enough, and we considered plasma. However, none of them unfortunately made it. So what happened to these 130 patients? Almost 90% recovered, alhamdulillah. 116 recovered through their COVID storm, and unfortunately we lost about 14 patients. One of them was as an outpatient, and it was a sudden death, not really linked to any respiratory symptoms. AKI was seen in 36 patients out of the 71 admitted, so 50%. 8 of the 36 required renal replacement therapy. 16 patients lost their grafts, and I just want to draw your attention that out of the 16, 14 were those who died. So 2 survived their COVID, however, lost their graft. Secondary infection was so common, was seen in 43%. And upon follow-up, the 28-day creatinine was basically normal in both patients managed as an outpatient and inpatient, about 95. So we did multivariate analysis for certain risk factors: age, creatinine and presentation, use of azithromycin, and development of AKI were associated with higher risk of mortality, and requiring renal replacement therapy and development of secondary infection were associated with higher risk of losing the graft. So in conclusion, we could say that transplant patients may experience a wide range of COVID-19 disease severity. We've seen completely asymptomatic patients who had the confirmation of their infection upon screening because of contact. And we've seen also in the spectrum of the disease, very or critically ill patients with the multi-organ failure requiring all types of support. The management can be done safely as an outpatient. If you remember the first table I showed, there was a higher rate of hospitalization during the first few months of the pandemic. However, we've seen in our study that we could manage a higher percentage of population as an outpatient. Another important factor, we have a younger generation or a younger population compared to the other studies from the rest of the world. Patients who are requiring or who required admission may experience poor outcomes with the high risks of ARDS and mortality. Despite having multiple therapeutic or antimicrobial agents, immunosuppression adjustment is still the main step of managing such patients. Unfortunately, until now, we don't believe that there is strong evidence preferring one agent compared to the other. And I think that's the last slide. Thank you so much.
Thank you a lot. Thank you a lot, Dr. Mettab. It was really very rich and interesting and exciting presentation. We already have some questions. However, استسمحك عذرا إذا ممكن we can move to the next presentation because time constraint, and we combine both discussion at the same time. So I will take the next presentation by Dr. Bishr Al-Attar. It's a presentation, another interesting topic about kidney health indicators in Saudi Arabia. Please, Dr. Al-Attar, if you don't mind, I will give you 20 minutes, and if you can concise it in shorter time, even better, so we can have some time for questions for both presentation, yours and Dr. Mettab Al-Bukumi. So the mic is yours, Dr. Bishr Al-Attar.
Thank you very much, Dr. Hanan. Okay, I'll promise to make it short as possible, especially this is the last presentation in this first day. So I'm going to summarize for you the kidney health indicator in Saudi Arabia. In order to obtain a national data on the characteristics of renal replacement therapy, we use a cross-sectional study based on a questionnaires filled out by dialysis centers in the kingdom. So every week, every first week of the year, the annual questionnaire, HD and PD, will be sent to all dialysis centers via email, mail, and fax. And once the questionnaire were filled out, will be sent back to Scott and will be encoded for analysis and validation. And this form includes 4 sections. The first one is about information about the staff. The second is about machine and capacity in dialysis unit. Then about the quality care management of patients, including the causes of renal failure, hepatitis, management of anemia, phosphocalcic balance management, and mortality. And the last section is about renal transplantation, if their patient were screened or prepared to be included in the waiting list, or how many patients went abroad for kidney transplantation outside the country. So it's after we're receiving all form, if in any inaccuracies or discrepancy were found, it will be verified from the dialysis by phone calls. And once validated, a comprehensive cross-sectional study will take place and final report will be made. So I'm presenting the data published last year. This is about by end of 2019. Currently, we are working on 2020, but not yet formal and final report. So just to summarize for you based on the data published last year. So the total number of hemodialysis machines in the country, 8,165, serving 19,522 patients on dialysis, overall 278 dialysis units. As hemodialysis center, 48% belong MOH, 9% governmental non-MOH, and we have private charitable hospital, 19%, and MOH outsourcing dialysis program, 22%. And if you look by patients, the majority, 65% belong to MOH, 27%, about 5,250 patients running dialysis by Ministry of Health, and another 7,000 patients running by outsourcing dialysis program. Then we have 1,200 patients under King Abdullah Hemodialysis Project, and 2,900 patients private and charitable hospital, in addition to 2,994 patients under governmental non-MOH. Here you can see the distribution between MOH and non-MOH, and currently Diaverum having 4,400 patients under dialysis by Diaverum, and Davita 21%, 2,662 patients under Diaverum. And here we record the number entered in dialysis program every year. Last year recorded 4,146 patients recorded in dialysis. Male to female, almost as universal one, 56%, 44, male, female. As non-Saudi, we have 17% of our dialysis population are non-Saudis. And according to the age group, pediatric patient on dialysis, only 112 patients below the age of 14. And the majority of our patients, more than 11,000 patients between the age of 26 to 56 years old. And we noticed an increase in number of patients on dialysis, regular dialysis with the age over 75, 1,924. As vascular access, the majority 62% with direct arteriovenous fistula. And then we have perm CATs in 30%, vascular graft 5%, and only the temporary access of femoral catheter is 3%. Here is the causes of renal failure. This year recorded 43% of patients in dialysis due to diabetic nephropathy, followed by hypertensive nephropathy in 34%, unknown etiology or glomerulonephritis 13%. You can see as prevalence of diabetes hypertension in dialysis population. So we have more than 75% of our patients are in red, are hypertensive. And here in orange, 15% having diabetes alone, and another diabetes with hypertension. Also about 50% of our dialysis population with diabetes. Patient treated on EPO as management of anemia in 74%, and having hemoglobin less than 10 gram is only 5% of our total population. And as indicator of comorbidity with the albumin less than 35 gram deciliter, we have 16% of our patients recorded with albumin level pre-dialysis less than 35 gram deciliter. As phosphocalcic balance, 23% of our patients with pre-dialysis phosphorus level above 1.9 millimole liter, and 38% of our patients with the calcium pre-dialysis less than 2.1, and 43% of our patients receiving non-calcium phosphate binder, 28% on calcimimetic, and 18% receiving vitamin D injectable, while the majority, 48% with vitamin D oral. As hepatitis C, we have 8%, 1,500 patients with HCV positive antibody. And for hepatitis B, we have only 3%, 500 patients with hepatitis B antigen positive. I'm sorry, this is the, okay, this is more information about the HCV. We have the PCR in positive patient, only 15%. So 260 patients out of 1,000 positive patients have the PCR positive. Then if we look on all parameters for this information sensor at the end of the year, we group the information based on 5 regions. So we can find what is the number of units per region, Western, Central, Southern, Eastern, and Northern. Or you can find the number of patients, hepatitis, positive, negative, pediatric group per region, diabetic patient or elderly patient, either per region, blood group, vascular access, or we have it per hemodialysis by sectors. So we can see how many units belong to MOH, how many units belong to the Averum, the Vita, other governmental, private, and King Abdullah project. And we can see the same information as manpower, how many consultants, nephrologists in Saudi Arabia, out of 278 dialysis units, we have 337 consultant nephrologists, 486 specialists, and GP 456, with 4,600 nursing staff, and number of machine, I mentioned it, and number of transplant follow-up patients, 7,000 patients. Also, we have currently the new classification that use it by region-wise. This is followed by the Ministry of Health that we have 13 regions. So the same information, you can review it according to Mecca, Jeddah, Ta'if with Qunfuda, or Riyadh region, Eastern, Asir, Jizan, Medina, Qasim, Tabuk, Ha'il, North Border, Najran, Al-Juf, and Al-Baha. The same information about manpower, number of patients, number of transplant patient follow-up, number of patient, new patient admitted, hepatitis B or C, the pediatric and elderly, diabetic, and hypertensive group. The second questionnaire is about peritoneal dialysis. It includes the number, type of peritoneal dialysis, pediatric or adult, and hepatitis. And we have a total of 1,500 patients on peritoneal dialysis. As Saudi, non-Saudi, 97% Saudi, only 3% non-Saudis. But we have as an pediatric group, 14% versus 86 in adult. Diabetic, we have the diabetic patient under peritoneal dialysis, 32%. And here positive HCV positive antibody patient, only 38 patient, 2%, and only 15 patient with hepatitis B antigen positive. The same classification in order to find how many hospitals are practicing the peritoneal dialysis according to the 5 regions, or how many patients or type of peritoneal dialysis use, pediatric and adult. And you can see that pediatric, we have 213. Mostly common use is CCPD, or automated peritoneal dialysis, 1,182 patients out of 1,546 patients under the cyclic or automated. While the CAPD, 224, then followed by intermittent peritoneal dialysis, 140. New patients, mostly the peritoneal dialysis, we saw that the majority are under the governmental non-MOH hospital, 938 patients versus 600 under MOH. And the pediatric group, good part of the patient on peritoneal dialysis, 213 are pediatric. And here the trend of renal replacement therapy, if you can see in gray, the hemodialysis patient with constant increase, Last year, we consider the net increase is 2.6%. We reached 19,522. And in red, we have the PD, steady one, not significant increase in the number, 1,500 compared to 1,500 year before, and the number of post-transplant follow-up, 7,000 patients. With this, we can estimate the prevalence and incidence of treated patients by dialysis, and as a total is the prevalence estimated to be at 631 patients per million population in prevalence, and the incidence is 142 patients per million population per year. But because of the variation in the population between Saudi and non-Saudi category, if we did the calculation about prevalence and incidence on the Saudi population, we find that the number of prevalence increased from 631 to 850 per million population per year, and the incidence increased from 142 to 189 per million population per year. Few words about the kidney transplantation in Saudi Arabia. This is in blue, with significant increase in the last decade for the kidney transplantation from living donor. By the end of 2019, 981 living kidney transplantation, deceased 140, and number of patients recorded that get transplant outside the country, 215 patients. And if we look on the all active transplant center in the country, total of 12 governmental and 4 private, total of in 1,127 kidney transplant in 2019. And because of COVID era, all affected with the number of elective, even the living and deceased, and we get transplant last year, 546 transplant. The importance of having any annual or national data is to compare our data with the international statistics. And here the example of USRDS, one of the more robust data used. And if we look on the chapter of international comparison, we can see that Saudi Arabia having a prevalence of treated ESRD in green between 100 to 200, as Turkey, France, Italy, UK, most Scandinavian country, and China, and in South Africa. While the highest country is United States in dark blue between 300 to 400, and the exception with exceed the number of 400 is Mexico and Taiwan. So here the incidence rate of treated ESRD patient, Saudi Arabia in the middle, worldwide 165 patient per million population, and the prevalence of treated ESRD 846 per million population, and as dialysis 613 patient per million population, the highest recorded in Taiwan, more than 3,400 patients, and the average in European country is between 900 to 600. As distribution of dialysis modality, still we are using the in-center hemodialysis, the majority, so more than 80%, and in blue is CAPD, APD, or OTPD. Great difference between other countries as Mexico, where they have the very active peritoneal dialysis, almost 35 to 40%. Colombia as well, some Scandinavian country and Canada, and in home center, which is very good alternative in some Scandinavian country, in Canada, in Hong Kong, while still not available in Saudi Arabia. Here the percentage and type of distribution of kidney transplant by donor. So 80% from living, 30% from deceased, and prevalence of patients with functioning kidney transplant per country. We have a record of 232 patients per million population per year. And all in all, if we look on the distribution of ESRD treatment modality per country, almost like United States, kidney transplant 30%, the majority of hemodialysis, but in center hemodialysis, less than 10% in peritoneal dialysis, with only the non-availability of home hemodialysis until now. With this, I will conclude, and thank you very much.
Thank you, Dr. Bishr Attar. Very elegant presentation as usual. Nice study, and thank you for all your contribution and your help. You're one of the senior expertise in organ transplantation and the Saudi Center of Organ Transplantation. We all, generation after generation, learned from you. With the limited time, and really we are enjoying it, but we have to really constrain the question. We'll take some of the question, and I see a lot of questions regarding the previous presentation. Dr. Gomi is around, and we'll take a couple of questions regarding the COVID and kidney transplantation. So we'll start from the last question that I'm seeing. Is about the vaccine efficacy in precaution in kidney transplant patient. What's the Dr. Mata?
I think this is a great and at the same time tough question because I'm seeing or hearing this question every time in the clinic.
Mm-hmm.
So when it comes to efficacy, there are no solid data. The only data was available or was published was a letter to editor in JAMA a few weeks ago, and they just measured the antibodies after the first dose. So the antibodies were low. However, again, it was after the first dose, and we know in the general population, after the first dose, the antibodies might be seen in 50% of those who received the first dose. So we cannot really talk confidently about the efficacy of the vaccine in a transplant patient, but we recommend everybody to take it. Basically, I think we have a huge number of people who have received the COVID. I showed the vaccine. I showed the number of COVID-infected people was about 130 million. The number of vaccinated people exceeded that number. In Saudi Arabia, we exceeded 5 million. And we barely hear about or heard about any serious side effects. So in general, it is considered safe. I encouraged all the transplant recipients to take it. There are no certain precautions with regards to it. The first year or people who had a kidney within the last year might not really have a good response to the vaccine, like the flu vaccine in seasonal flu vaccine.
I have a question myself. Do we have really a clear data? When is it the safest time before surgery, before transplant, to take the vaccine, and after transplant timing, the best optimal time, before and after?
So, yeah, so I don't think we have data supporting that. But as I mentioned by the first question, I think after the transplant, the first year the response is not guaranteed, and we've seen that with the flu vaccine. So it is preferred to take the vaccine before the surgery. We don't have data for the patient with kidney disease. We have general population that showed by the second week of the second dose, they are forming antibodies. I'm not quite sure if there are any data available for somebody with chronic kidney disease or on dialysis. If the patient is having a planned surgery within the next 2 to 3 months, it would be a good idea to receive the vaccine.
Mm-hmm. I have a question here. I think you or Dr. Bishr Attar can answer. For patients with proteinuria, what is the permissible amount of daily protein? What do you recommend?
Well, we know the kidney is trying both kidneys trying their best to reabsorb all the protein. So when we do a dipstick, there should be no protein seen in the dipstick. And the absolute number is variable between references, but anything below 150, some references might go to 300 milligram is reasonable and considered normal. But anything above that is labeled as proteinuria.
Again, regarding COVID post-transplant, patient who got infected with COVID post-transplant, there is a rule for IV immunoglobulin? Or we know there is a rule, but I mean, post-transplant, how it is different than the normal population?
Yeah, well, to be honest with you, I haven't come across any studies or any publication that used IVIG in COVID patients. Plasma exchange was used for patients with COVID, and we tried it in 7 patients. However, such invasive, if I may say, procedure would come the last. So it would be tried in a sick, very sick patient. So it might be unfair to comment on their efficacy. I haven't come across IVIG in COVID, and we haven't used it in the 130 patient. If I may think about an occasion that IVIG could be used, if somebody unlucky having rejection and COVID at the same time, IVIG might have a role, but I cannot build it in a very strong evidence, because that's what we do when we have BK nephropathy and rejection at the same time.
Do you do any modification of the immunosuppression if the patient
Yes.
So roughly what's exactly you worry about immunosuppression wise after the transplant?
So COVID, like any other infection, when a patient develops an infection, we start lighting up their immunosuppressive medication. We start with the antimetabolite basic, and we showed in the study we've done that almost 98% of those who were admitted had their MMF as antimetabolite stopped completely. So the first step is to stop mycophenolate or myfortic or azathioprine if patient taking it. And then, depending on the situation of the patient, if the patient is sick, reducing tacrolimus would be a reasonable approach. If the patient is critically sick and you are in the area choosing between his kidney and his life, I think his life is more valuable. So we stop everything and leave the steroid. Basically, the steroids here might be considered as used as dexamethasone, and we have evidence that it is one of the agents used during the pandemic that showed significant survival benefit in patients with ARDS. Or in septic patient, hydrocortisone is used as a main treatment modality for septic shock. So start with antimetabolite, lighting up tacrolimus or CNI general. If the patient is sick, stop both and continue with the steroid.
Dr. Bkoumi, Dr. Attar, all distinguished speaker. MashaAllah, 136 participants still alive. We thank you all. We really enjoyed all the presentation, and I'm sure there is a lot of questions, and still we have another day tomorrow. Tomorrow, inshallah, we exceeded the time actually, and tomorrow, inshallah, we reconvene at exactly 5 o'clock. We have also very distinguished speaker and important presentation, different from different spectrum. Again, and I cannot overemphasize the team, event troops and ITHAR team also behind the scene. They did a very great job, and they kept all the things that are running in very, very high standard. So thank you all. Enjoy your night, and see you tomorrow, inshallah. Goodbye.
Thank you.
مع السلامة.